Good evening and welcome to the latest instalment of Podiatry in 3 Minutes, a live webinar where we challenge a researcher to explain their most recent podiatry-related publication in just 3 minutes.
Today, myself and Sinead will be your presenters. My name is Jennifer Dowdall and I'm a MSK Specialist Podiatrist at Sheffield Teaching Hospitals and a Research Assistant at Leeds University and Leeds Teaching Hospitals.
And I'm Sinead and I'm a postgraduate researcher in NUI Galway.
And of course, in the background, we have Michael Stevenston, who's pushing all the buttons and making sure everything runs smoothly in the background.
The researcher who will be explaining their paper and a researcher or clinician who's an expert in that field to discuss it with them afterwards.
After the 3 minutes are up, the two guests will discuss how the published works exist within the surrounding body of evidence and how we may be able to apply their work to our clinical practice. Following this, we will open up the floor to questions from the public. So let's introduce today's guests, Joanne and Andrew.
So welcome on, Joanne and Andrew. Thanks for joining us. So up first, we have Joanne. Dr. Joanne Paton is a podiatrist, researcher and program lead of the MSc Pre-Reg Podiatry Apprenticeship at University of Plymouth. She has extensive clinical experience in biomechanics of the diabetic foot and has been awarded 2 prestigious NIHR Clinical Trials Fellowships to support her work. Her current clinical focus is improving the patient experience and diabetic foot health through interventions that support patients at risk of diabetic foot ulcers. Joanne leads the EUP Balance Enhancement and Ulcer Prevention Research Team at Plymouth University. She has secured grants in excess of £1 million and published widely on the topic of insoles for ulcer prevention and balance enhancement in diabetes. Thanks for joining us, Joanne.
And of course, we have Andrew. Andrew Hill is a podiatrist who qualified from the University of Brighton in 2006. He has worked in both the NHS and private sectors before moving into education. Andrew has recently been appointed programme lead for the undergraduate podiatry degree being delivered by the SME Institute. In 2015, he obtained his Masters in Podiatry from the Queen's Margaret University, where his dissertation focused on determining the patient-perceived impacts of patient education in diabetes. He is soon to submit his professional doctorate thesis at the University of Bath, where he is exploring the patient and healthcare professionals' perspectives on barriers and facilitators to good foot self-care practices in people with diabetes at low risk of developing foot problems. The area of patient behaviours, patient education and motivation in diabetes are a core area of professional interest for Andrew, and he has published papers on these topics and acts as a peer reviewer for the Diabetic Foot and Patient Education and Counselling journals. You're very welcome, and thanks for joining us, Andrew.
Thank you.
Okay, Joanne, are you ready to go?
Yep.
Best of luck.
Thank you. Good evening, everybody. I'm here today to talk to you about my paper, Behaviour Change Approaches for Individuals with Diabetes to Improve Foot Self-Management, and it's a scoping review. Okay, so first of all, I'd like to acknowledge my co-authors and then begin with my 3 minutes. So don't walk barefoot. Check feet daily. Why is it so difficult for patients to follow such simple foot care advice? Our research set out to answer that question and to provide a recipe to make things better. So what we did was we looked at the literature across the whole topic, and we mapped the components of each intervention against something called the behaviour change wheel, to see which occurred with most frequency and which was associated with a positive change in patient behaviour. So the behaviour change wheel was published by Mickey, and it's a behaviour change framework which suggests that in order to elicit a behaviour change, you need to have 3 integrated essential components, and they are capability, opportunity, and motivation. And when we looked at the behaviour, the interventions and the components of those interventions, we found that most of them focused very much on capability. Missing was opportunity and motivation. So what we did then was have a look at those interventions that actually had a really positive effect on behaviour, or actually changed patient behaviour, to see the recipe for success. And what we found was that to actually change patient behaviour, it wasn't enough just to provide education. What you needed to do was provide capability in the form of education, in combination with motivation, or capability in the form of education in the combination with opportunity. Now, what does that mean clinically? Well, motivation, to get motivation clinically, you can do this by delivering it using persuasion. So what you need to do here is elicit either positive or negative emotions from the patient about or related to the behaviour change. And in terms of opportunity, it's all about enablement. So that's removing barriers or providing objects that actually increase the patient's capability for the behaviour change. So, for example, having enough insoles in enough shoes, providing nail files, or providing mirrors. So what's the take-home message? Education alone is not enough if you want to actually change behaviour. What you need to also incorporate is either motivation in the form of persuasion, or indeed opportunity in the form of enablement. Thank you very much.
Thank you, Joanne, for your presentation, and well done for getting it in under 3 minutes. It's not always an easy task. How did you find it?
Fine, it was good, except my little boy came in halfway through, so I did my best to ignore him. I don't know if you picked that up. Came in and said, hi.
Okay.
So Andrew, following the presentation, is there anything further you think it may be useful to discuss, and any questions that you have for Joanne?
Sure. Well, thanks for that, Joanne. It's really useful to obviously hear one of the authors of the paper to actually present the findings that way. It certainly does help, and it's a really useful paper in so much as there has been, as you're probably aware from some of the systematic reviews that have shown us sort of consistently that education alone is not the answer, and certainly it's been a focus, I think, for a lot of research, a lot of intervention. So I suppose what I'm interested to find out really from you, just as a starting point, is, having done the scoping exercise, was there anything that came out of it that you found particularly unexpected or interesting?
Yeah, that's a good question. I guess for me, it was the idea that, or despite us knowing about this knowledge action gap, if you like, the interventions that were being tested still focused very much on traditional education type delivery. And also, if you look at the interventions, there's a real sort of scattergun approach to the interventions. When you think about trying to change a patient's behaviour, these interventions, we're not trying to change one behaviour, but some of them were including up to 12 different behaviours they were trying to target and change. And that came before the paper. I didn't really think about it, and I guess it's something we do in clinical practice all the time. We give patients leaflets that have whole lists of things that they're supposed to take on board and go away and change. But after I'd completed the review, it was almost a bit like a light coming on in my head to say, actually, what are we really doing here? How can we really expect somebody to take this information and change behaviour when we're just throwing lots of information at them with no real other support? So I think that's probably most interesting.
Yeah, and I think it builds a lot on sort of gradual literature understanding, I think, of that point around just fixation on information and other components of it that maybe get somewhat more overlooked or omitted. I suppose what I found quite interesting, and I was kind of looking at the sort of motivation wheel model that you kind of use as a sort of framework, if you like, in order to kind of contextualize the literature. And another one that I had seen somewhat similar spoke of the information motivation behavioral framework. So essentially they like to bring those two elements together, that you need someone who's both informed but suitably well motivated. One of the things that was quite interesting from this model, and I wonder if maybe you could talk how you found it, because as I was sort of looking at it from the kind of diagrammatic point of view, it seemed to have quite a lot of attention and focus on what might be considered somewhat extrinsic factors. So things like persuasion or utilizing incentivization and different things that may be associated with behavior. And I just kind of wondered how you thought that might sit with some of the sort of self-determination stuff that kind of considers actually intrinsic motivators are fundamentally the most significant. So if someone either feels a particular activity is enjoyable, ideally, but in the absence of it being enjoyable, if it's suitably important enough for them, you'll often find motivation follows through. So I just kind of wondered kind of how you found using that model, because I've not really used that particular model myself much before.
Yeah, I mean, the reason I use that model is because not only is it useful in terms of analysing how an intervention has been put together, but it's also been used quite a lot in other disciplines in terms of how to develop an intervention. So I'm hoping that the paper is useful not only as a tool for pulling existing interventions apart, but then can be taken by clinicians and researchers to develop other interventions. Now, it's actually based around all the different behaviour change models that have been published over the years, and it was brought together by a panel of behaviour change experts who sort of merged them all in sort of like a literature review. Came up with this overarching model. What it allows you to do, because it has lots of different layers, if you like, is think of behaviour change in terms of, first of all, what is the problem that needs to be addressed? For example, we need to reduce foot ulceration. Then what is the behaviour that needs to be changed? So, for example, people need to check their feet daily, and then move on to how are we going to deliver that behaviour? And that's where those other elements come into play. So it could be, for example, persuasion, and you could achieve that through goal setting, motivational interviewing, and all those other tools that are out there that you may then use to deliver what it is that you're trying to influence. So it feels quite complicated when you look at it first of all, but actually when you break it down, it does sort of make some sort of systematic sense. So it's quite useful.
That's good. I mean, I think something that really did stand out to me, and you used the word a minute ago about the kind of scattergun approach that's taken. And one thing I've noted as well, having looked through a lot of this literature, is that you'll look at a paper that is focused on or talking about sort of inducing behaviour change in people, or getting people to begin and then sustain behaviours. And then very quickly, the focus comes back to how much information they're given, and they will kind of use how much does somebody know before and how much does somebody know after as the way that they sort of judge whether something was effective or not. But what none of it was looking at is addressing whether or not somebody's behaviour changed in that time. And one of the things I noted from the conclusion, I think, or at least the end part of the discussion of the paper of yours, was basically saying that one of the things you'd like to look at is a sort of maybe a sort of randomized controlled trial, look at the intervention, and then maybe map that against foot health outcomes or prevention of sort of first ulceration. And I suppose the point I thought was quite interesting, and I just kind of maybe wanted to gauge your thoughts on, was one of the things that we can be guilty of fixating on, I certainly know I'm guilty of this, is thinking that if we can just change behaviour in this particular sphere and we can get people doing right things, whether it be checking their feet or signposting when they think they've got a foot problem, they could theoretically do those things very well. But if the other aspects of their behaviour, let's say, for example, around calorie intake or blood glucose levels, if those things remain not well addressed, then you then can think about the confounding factors. So I'm almost wondering if maybe we need to look at trials which are designed purely at taking patients from behaviour A to behaviour B. And then once we've established a model that works that way, if we then look at behaviour B and what that means about foot health outcomes, I just kind of wondered your thoughts on that.
Yeah, crikey. So I guess what you're hinting at really is, should we be focusing our education or our advice on patients who before they develop foot ulceration, first of all, and what outcomes should we be measuring? So in terms of outcomes we should be measuring, that's tricky because often we're talking about prevention. So it's always difficult to measure whether something has been prevented. But I think with behaviour change, whatever intervention you're looking at, whether it's foot health or blood sugar management and lifestyle changes, I think you've got to measure both your long-term health impact, because ultimately that's what you're trying to alter or influence. But then it's really important to understand the active ingredient of that intervention. So, is the active ingredient an increase in educational knowledge? Is the active ingredient change in the behaviour? So I think when you're looking at trials or even in the clinical setting, it's important to think about both long-term foot health, but also shorter-term knowledge and behaviour and all the sort of intervention recipe that may or may not be feeding into that end goal. And then in terms of where we start our behaviour change therapy, which I think is probably what you were alluding to, that's a really difficult question. And, you wonder whether if you're looking at people with very low foot ulcer risk and you're looking at lifestyle changes in blood glucose management, whether that's almost a public health exercise. And you're looking at a very complex intervention, including multi-professionals as well. So that's quite difficult to put in a trial. Although actually in the NHS, when you look at integrated care pathways, it's absolutely how patient care is managed. But of course, in the NHS, they tend to focus on foot pathology. The money is spent on the patients that cost the money, and the patients that cost the money are those who sadly and unfortunately have already suffered the burden of a foot ulcer. But if we hope to turn the tide, then at some point we're going to have to take a step back and look at earlier in the disease management to start preventing some of these confounding factors ever developing into the complications that we see and the foot problems that cause such devastation to our patients. So I'm not sure, did that answer your question? Or
Yeah, no, it certainly, it was a very big sort of meandering question that I had. So yeah, no, it certainly addressed different factors of it.
Just to pop on there and say, if anyone who's watching wants to ask a question, do make sure to pop it into the comments there, and we'll address it in a few minutes.
Perfect. I think just sort of following on from those points, actually. Yeah, absolutely. You know, the sort of early tackling is becoming sort of ever more crucially important. And I suppose just to sort of link this for people into kind of a message, if you like, take home or clinical relevance. I suppose one of the things that's really stuck out to me, and again, I'll be interested to hear Joanne's thoughts on this, is that I often find that when we are looking at either instilling behaviours or actually asking patients to turn from one behaviour into a more preferable behaviour, so actually those are two different things. One might be starting a behaviour off, and one might be actually trying to stop a detrimental behaviour and actually turn it towards a more beneficial one. You generally find that there are two sort of factors to it, and we've alluded to it already, one being information, one being suitable sort of motivation or capability of doing it. And actually, I think the clinical take home is to try your best as a clinician to identify where the gap is. Because if you've got a suitably motivated patient who's very well engaged, understands that foot health is a problem, etc., but doesn't really know what they're supposed to be doing or doesn't know what they have to do, then it would stand to reason that focusing on provision of useful information is going to be highly effective. But you could have a highly informed patient who maybe lacks motivation or capability, and actually you then need to target what you could do as a clinician to help either instill some of those desires and motivations through some of the techniques Joanne's discussed, or indeed maybe find ways to make things more capable for them, more tangible. And certainly from a study that I've been doing, tangibility and routine seem to come out often from patients when you talk to them, and even from health professionals, that if they can understand the cause and effect of what you're asking them to do, that can be a real tangible they can get hold of. And also if they can view it from the perspective of, actually, if I build this into my routine, it can become behaviours they do that they then don't consciously think about anymore, and that can sometimes be possibly an effective tool that we could look at as well.
Yeah, I find with patients that have had ulcers or amputations often are motivated because they absolutely have seen the effect of diabetes, and that's enough to worry them enough to do something about it. The more of the challenge is those who haven't had a foot ulcer, and in that instance it's really hard to get over to them that they are at indeed risk. And in that context, providing education alone isn't enough. And what I would recommend that you do is try and understand what it is that the patient wants to get out of changing the behaviour. So, for example, I don't know, if it's wearing insoles all of the daytime, then that might be linked, for example, with, well, I'd like to increase my mobility, I'd like to walk the dog more frequently. So if you can provide a motivator so that they can see a here and now benefit from whatever the behaviour change you're attempting to ask them to undertake, then in my clinical experience, that often is really helpful. Yeah, so that would be some advice.
Brilliant. Okay, I think that's great. Thanks very much, Andrew, for your input there. I think it's time we'll head over for some questions from the audience, if that's okay. So we have a question coming in from Rob Menzies, and he asks, what would be your perspective on this cognitive dissonance and other known factors, diabetes-induced dementia and compression of patient education, and how would you overcome the hurdles associated with patients with diabetes fearing amputation more than the fear of death?
Well, okay, so I think there's two questions there. First of all, there's one, I think, about diabetes and its effect on cognitive function, and I think that is well known, and we see that in our clinics all the time. particularly with patients just not being able to retain information. Often the treatment burden for diabetes is massive. You've got to put into perspective whatever advice and behaviour change you're asking them to do within your own clinic, then you can treble that with all the cardiovascular risk factor advice and the blood glucose management and the dietary advice. And often the feet are just, one thing too many to take on board. So in that situation, I think there are two things. First of all, where that patient has a carer who can help support them, and my clinic's full of lovely old gentlemen who are usually supported by lovely wives, and if they're lucky enough to have a wife that looks after them, then often it's the wife that provides the prompt for the behaviour change. So it's the wife that keeps the patient on track. But the second thing is, first of all, you need to make sure the advice is at a level that the patient can understand. So, being careful with terminology, but also the advantage that as podiatrists, we see them every 3 months, so don't think of giving advice in one hit and then never talking about it again. It's behaviour change, I think you've got to see as a long-term drip feed. And so that would be my advice there. And in terms of fearing amputation more than the fear of death, I think sometimes patients, particularly who have had relatives who have suffered for amputation, particularly that's a fear for and a motivator for, in fact, looking after their foot health. I haven't really seen it personally as a concern. I think if I were a patient, I'd probably fear amputation pretty much. It's pretty serious. It's pretty life changing. So I don't think I see that as a hurdle, actually. But I may not be interpreting the question correctly. So Andrew, I don't know if you want to add.
Yeah, a couple of little thoughts. I mean, I think there's a couple, again, you're quite right, there's a few bits to what Rob's asked there. I think the point about cognitive dissonance is one we see absolutely across multi conditions where behaviour change is a necessity. And, it comes back to the sort of central tenets of motivational interviewing, where we know that people will hold conflicting views about something. They will have a motivation on some level to make a change, and they'll also have pretty good reasons for the status quo to stay the same. And where both of those are in some form of balance, what you're ultimately going to find is the individual stays not acting in a particular way because the status quo is quite strong. And so sometimes, using some of the motivation interviewing techniques might enable somebody to work through their cognitive dissonance and actually come to a place where they are moving in the direction of change. The point about fear is fascinating, though, and again, I'm keen not to talk too much about my own studies at the moment because they haven't gone through peer review and stuff. But the points that have been raised, it's been quite reassuring to hear them echoed, because absolutely a lot of things that have come through from patients has been family members, so those who've lost limbs to diabetes. It seems to be a huge motivating factor. And I had one gentleman who actually said he would sooner die than lose his foot to diabetes because he's worried about the impact on his family if he becomes disabled. Whereas if he just died, he sort of feels like he would leave them some money and they'd be okay. And so it almost brought those two worlds together, where there was this feeling that actually I do fear amputation more than death, but it aligned very much with the impact of family. So I definitely think involving family in patient consultation and within the therapeutic alliance is potentially a very effective thing to do. Of course, the patient would have to be happy and want that to be part of the process, but involving family for the reasons Joanne said, by having a partner who might actually act like a supportive spotter and somebody who can help them with behaviours, but also because involving the family can mean that you are including something that's extremely important to somebody and turn it into a bit of an intrinsic motivator. So I think fear can be, if it's sort of naturally occurring for somebody and it's well used and harnessed, it could probably be quite effective. But of course, we've always got the other concern that if fear is utilized as a tool for communication, it could have a backfiring effect, and it could actually make somebody sort of spiral into maybe a bit more of a depth of depression or something, which can then possibly result in them taking less care of themselves because they don't see the point or whatever. Yeah.
Great, thank you.
So our next question is going to be from Nina Davies. She's asked, should we use patients as part of our paid workforce to deliver education and share their lived experiences of foot ulceration?
It's a good question.
Yeah, I this is just a personal view, but I think absolutely. In terms of when you work in the research arena, then you wouldn't dream of moving forward with a research project without having a patient representative on the grant writing part of it, and lots of patient and public involvement. And yet in the clinical side of things, although there's a lot about patient-centered care, actually patients are still very much the people we do things to. They're not, in terms of properly giving them ownership for their care, and properly giving them a voice in terms of how services are delivered and what's relevant to them and what their actual needs are and how to meet those needs. I think we still have a really long way to go. So if we could get patients on the workforce and part of service delivery and part of service design, I think we'd be in a much better place. And also, I think in terms of motivating patients to change behaviour, other patients, then I think that would be invaluable, because again, it's lived experience. It's all those nuances that, as a clinician, having never tried to make that behaviour change, you can't have insight to. But if you talk to another patient who's travelled that journey, it's those little tips like, well, make sure you have 2 pairs of slippers, one by your bed and one by your chair, and then getting to use your slippers all day suddenly becomes easy. And don't worry about having to wear therapeutic shoes. If you choose the shoes that are the same colour as your trousers, people don't notice them. It's those sorts of top tips that can only come from patients with a lived experience that I think the NHS would be a much richer and more patient-centered place. So
I'd certainly echo those thoughts, and just to sort of add that I have been aware of a few patients who have actually been involved in local diabetes education programs, both sometimes with regards to feet, but in other facets as well. And it's certainly been very positively received to have the lived experience shared, exactly as Joanne said. And just one final point that touches on that a little. One of the things we have to be conscious of is that there can be communication issues that occur between practitioner and patient. And when you get some sort of breakdown in communication, that can have an implicit impact on trust. And if we lose a little bit of trust in the relationship, that can mean advice that's forthcoming is less likely to be impactful. Whereas sometimes if that same advice is coming from a patient with lived experience, those issues of trust might be a little bit less sort of clear and obviously there. And that, for example, could possibly, all add to the greater, the greater benefit of patients. So yeah, I think there is some merit in looking at.
Excellent. I think that's probably all we have time for this evening. Thanks very much for such an in-depth discussion, Joanne and Andrew. So have you any just one-liner take-home message, Joanne, for the audience?
Yeah, I guess the take-home message is education isn't enough, and you do need to motivate and enable your patients to make that behaviour change. So good luck with that, and see what you can come up with.
Brilliant. Thanks very much. And just to say that tomorrow's Podiatry Awards are now open for nominations. And this year there's a new award for Researcher of the Year. So do check it out, and why not nominate a researcher in podiatry who you feel is deserving of the award. And our next installment of Podiatry in 3, we will have Alfred Gatt on talking about his paper on ankle dorsiflexion.